are going to continue with the investigations and management of thyroid conditions. Today, we are going to talk about the various investigations that are requested for when you manage a patient with an anterior neck swelling, with a goiter, and also the various treatment options that are available, especially for managing a toxic goiter and also a non-toxic multinodular goiter. So we are also going to talk about the complications of the surgery after the surgical options. Now, the various investigations that are requested when a patient presents with a goiter, you request for a thyroid function test. And in the thyroid function test, you are going to assess the T3, T4, TSH. We will also request for a neck ultrasound scan, a high-resolution ultrasound scan. We also request for a fine needle aspiration cytology. We request for a neck X-ray, thyroid scan, that is radioisotope scan, iodine scan. We also request for a CT scan when it is indicated. Okay, we will also request for a laryngoscopy. Okay, we are going to see all these investigations in detail. Now, for the thyroid function test, we assess for the thyroid stimulating hormone, okay, the free thyroxine and the free triiodothyronine. We should know that it is the free one, as we discussed in our previous lecture, that it is the free form that are active, not the physiologically bound hormones. Now, this is the various interpretations for the thyroid function tests. For thyrotoxicosis, the T3 is elevated, T4 is elevated, the thyroid stimulating hormone is suppressed. For the hypothyroidism, the T3 is low, T4 is low, thyroid stimulating hormone is elevated. For the T3 toxicosis, the T3 is elevated, thyroxine is normal, TSH is suppressed. For elevated T4 toxicity, the T3 is normal, the T4 is elevated, TSH is suppressed. And this is common in toxicosis. We should also know that serum calcitonin, though not part of the thyroid function test, is also a hormone that is produced by the parafollicular cells of the thyroid gland. However, this is not part of the routine thyroid function test. However, you will see serum calcium is also requested for. so that we have baseline calcium and phosphates. You know, if there's an inadvertent injury to the parathyroid gland, patient will present with hypocalcemia. The thyroid autoantibody level is more than 90% in patients with Hashimoto's thyroiditis, and 80% of patients with Graves' disease have antimicrosomal antibodies. So these are also assessed if you are thinking of this mentioned condition. The neck ultrasound scan, a high-resolution ultrasound scan of the neck. Okay, the purpose, one, it defines the nature of the swelling, whether the swelling is cystic or solid. It also tells you the origin, that this swelling originates from the thyroid gland. You can also assess the cervical lymph nodes. It can also guide you to do a ultrasound-guided fine needle aspiration cytology. These are various rules of ultrasound scan in evaluating the thyroid gland. The fine needle aspiration cytology is taken to determine if it's a benign or a malignant goiter. However, you should know there are some limitations for evaluating a goiter with fine needle aspiration cytology, especially for follicular neoplasm. Follicular neoplasms are either adenomas, that is benign, or carcinomas. However, the fine needle aspiration cytology cannot differentiate follicular adenoma from follicular carcinoma. So it just shows you a follicular neoplasm, because for follicular adenoma and carcinoma, it is differentiated by a vascular or capsular invasion. And this can only be achieved using a true cut biopsy or a tissue biopsy. However, there are various ways the fine needle aspiration cytology is interpreted when it is taken for a goiter. It is reported from Type 1 to 5. Okay, Type 1 is non-diagnostic. Type 1C is non-diagnostic, cystic. Type 2 is non-neoplastic. Then type 3 is follicular, and type 4 is suspicious for malignancy, while type 5 is malignant. And you should know, for fine needle aspiration cytology in reporting a malignant cells show pleomorphism, okay? Increase nuclear cytoplasmic ratio, increase mitotic figures, and hyperchromasia. These are some findings you notice for malignant cells on fine needle aspiration cytology. So CT scan, what is the role of CT scan in a patient with goiter. Now, it's not all patients with goiter you request for a CT scan. You request for a CT scan when you suspect a retrosternal extension. Retrosternal extension of the goiter. The CT scan will also help you in evaluating the lymph nodes of the neck. And if you suspect a malignant lesion, it can also assess the level of infiltration of adjacent tissue. But however, the CT scan is not a routine investigation you do for the evaluation of an anterior neck swelling. Now, the radioisotope study. Now, you use either an iodine 123, okay, or technetium 99 for radioisotope study. It is called a thyroid scan. It is called a thyroid scan. Now, it is preferred to use technetium 99 over the iodine 123 because the iodine 123, the radioisotope iodine 123 has more irradiation. So there is more exposure to irradiation, while the technetium 99 has a lower energy radiation. That is one reason. Secondly, if you look at the half-lives and the duration of the scan. Now, after administration of technetium 99, the scanning is done in 20 minutes, okay? And the overall half-life of that technetium 99 is 6 hours. So you get your reports in a shorter period. But for radioisotope iodine, when you administer the drug, the scanning is done in 24 hours and it has a longer half-life of up to 48 hours. So you see the patients have to be isolated for the duration of the half-life because of the emission of radiation. The next investigation that we'll talk about is the X-rays, the radiographs. What are the various roles of X-ray in evaluating a patient with an anterior neck swelling? Now, for the X-rays of the neck, AP and lateral is done. For a goiter, you look for AP view, you will see a soft tissue shadow, a soft tissue shadow in the neck. It also shows you position of the trachea, whether there is deviation, okay, whether there is deviation of the trachea or the trachea is central. Then you also look for calcifications. You could have a stipple calcifications, okay? Stipple calcifications in papillary thyroid cancer. Or you could have a coarse calcification in a long-standing multinodular goiter. Now, you should know that this stipple calcification you see in papillary thyroid cancer, they are representation of psammoma bodies. On X-ray, they appear as stipple calcifications. And these psammoma bodies are pathognomonic for papillary thyroid cancers. Okay, the lateral view The lateral view of the X-ray, of the neck X-ray, will show compression of the trachea, tracheal compression. You also look for cervical spondylosis. Okay, so now with compression of the trachea, this lateral X-ray is very important for the anesthetist, okay, so that they can plan for intubation of the patient. So if there's compression of the trachea and cervical spondylosis, the anesthetist will anticipate a difficult intubation. So they have to make a proper preparation on intubation of the patient. Okay, so the X-rays, one can also request for a thoracic inlet X-ray, which will show a retrosternal extension of a goiter. The chest X-ray may also show a retrosternal extension. However, you request for chest X-ray when you are also looking for other conditions like cardiomegaly, unfolding of the aorta in patients with a background hypertensive disease. Now, laryngoscopy, direct laryngoscopy or fiber optic laryngoscopy, even though the indirect laryngoscopy is becoming obsolete, where you use series of mirrors to assess the vocal cord. Now, the aim of laryngoscopy is to assess the state of your vocal cord, okay? To assess the state of the vocal cord before surgery, because if there is paralysis, there could be an asymptomatic paralysis of the recurrent laryngeal nerve, okay? And they might have a partial paralysis, which is asymptomatic. So you want to assess that and document for medical legal reasons. So laryngoscopy should be done before thyroidectomy, either as an indirect laryngoscopy or a fiber optic type. Okay, now, aside laryngoscopy, other investigations you want to do will include ECG, especially for patients that are more than 40 years or patients with toxic goiter, because patients with toxic goiter will have arrhythmias. Some patients may have arrhythmias. Patient more than 40 years, hypertensive patient, and if there are abnormalities on the ECG, you further proceed to request for an echocardiography to assess the heart, ejection fraction, and other parameters. Now, you should request for other baseline investigations in preparing patients for treatment. This will include the full blood count and differentials, urea electrolyte creatinine, random blood sugar grouping and cross-matching, serum calcium and phosphate to get a baseline serum calcium and phosphates. We've talked about the fine needle aspiration cytology report. Now, what are the various treatment options for thyroid conditions? Let's talk about treatment of thyrotoxicosis. Now, the various treatment options for thyrotoxicosis include medical treatment, radioiodine treatment, as well as surgical treatment. Now, let's start with the medical treatment. The aim of the medical treatment is to render a patient euthyroid so that patient is relieved of the symptoms of thyrotoxicosis. And this is achieved using medications, the antithyroid drugs, which are in a class of drug called thioamides, and also the beta blockers. Okay, the aim of these drugs, this is to reduce the circulating thyroid hormones, and the beta blockers is to reduce the adrenergic symptoms they present with. Now, let us look at the antithyroid drugs. There are various types of drugs that are used in medical treatment. And if a patient is for strictly medical treatment, the treatment is offered for about 12 to 18 months. If patient is strictly for medical treatment alone, the treatment is offered for 12 to 18 months. Okay, now you should know that the drawback of this medical treatment alone is relapse. You should know that patients that are on only medical treatment, about 50% of these patients will relapse in 6 months. Within 6 months, they will present with the symptoms of thyrotoxicosis. Now, what are the various drugs that are used? Carbimazole, an antithyroid drug, okay, is given as loading dose and maintenance dose. Now, for carbimazole, what is the mechanism of action of carbimazole? We should know that carbimazole acts at various steps in the synthesis of thyroid hormones. One, it prevents uptake of iodine. It prevents coupling. It prevents coupling of iodine to tyrosine. And it prevents coupling of monoiodothyronine, diiodothyronine to produce the thyroid hormones. Okay? Okay, we are talking about the carbimazole. We've mentioned the various mechanisms of action of carbimazole, the various ways it prevents the synthesis of the hormone, mainly by preventing the binding of the iodine to tyrosine, and also it prevents the coupling of the monoiodothyronine to diiodothyronine and subsequent production of the hormones. We should know that this medication is administered as a loading dose, okay, of 15 to 20 milligrams 8 hourly. And it has a maintenance dose of 5 to 10 milligrams hourly. Now you should know that patient that is placed on a loading dose, patient placed on a loading dose of carbimazole, they become asymptomatic in the first 1 to 2 weeks. There is drastic reduction in the symptoms, and within 4 weeks, they become euthyroid. So clinically, within the first 2 weeks, there is significant reduction in the symptoms of thyrotoxicosis. Then in 4 weeks, the thyroid, when you do the thyroid function test, they are expected to be euthyroid. Then you now place them on the maintenance dose of 5 to 10 milligrams hourly. Now you should know that patients on carbimazole, they have risk of developing toxicity to the drug. The toxicity of carbimazole may include, they have skin rashes, okay? Skin rashes. They may have arthralgia. But most importantly, they have agranulocytosis. Most importantly, they have agranulocytosis, and patients with agranulocytosis, they will present with sore throat. And when they present with sore throat, you are expected to stop the drug. Because of the agranulocytosis and leukopenia, they have okay. Patients with agranulocytosis, they have tendency for what? They have tendency for sore throat, and you stop the medication and place them on antibiotics. Now, the other medications, let's see the other drugs aside carbimazole. Okay, metimazole is a long-acting, okay? It's prescribed 20 to 40 milligrams daily. It is more potent, okay, but not used in pregnancy. Carbimazole also is not prescribed in pregnancy. Proper thyroxine, 100 milligrams, is given 3 times daily, okay? And it can be used in pregnancy. You use a 50 milligrams tablet. The mechanism of action of propylthyroxine is preventing peripheral conversion of T4 to T3. For metimazole, metimazole has the same mechanism of action as carbimazole. Other antithyroid medications that can be given includes the Lugol's iodine. The Lugol's iodine contains potassium iodide and elemental iodine. It's given 10 drops 3 times daily. They prevent the uptake of iodine by the gland, okay? High doses of propranolol can be used as an antithyroid drug, okay, where it also prevents the uptake of iodine. Drugs that prevents production of antibodies in patients with autoimmune thyroid conditions like Hashimoto's thyroiditis. You can give steroids. Now, another advantage of this carbimazole, they have advantage of also stabilizing the autoimmune antibodies. Now you can give, you can do a therapy that is called block and replace therapy, where you give high doses of antithyroid drugs, then that completely blocks production of the hormone. Then you give a maintenance dose of L-thyroxine for replacing the hormonal function. The other category of drugs used in the medical therapy are the beta blockers, and their aim is to prevent the beta adrenergic symptoms. They control the cardiovascular and hyperadrenergic manifestation. Okay, now propranolol is given 40 milligrams 12 hours. Now, before we move into the next treatment, you should also be able to mention the indications for the medical treatment. Now, what are the indications for medical treatment? Now, patients, you can do medical treatment alone for children, okay? You can do medical treatment alone for adolescents, okay? You can do medical treatment alone for females, because females, they have more compliance, okay? They are more regular on medications and follow-up than males. These are some indications for medical treatment. Okay, let us proceed to let's proceed with the other form of treatment. Now, the radioactive iodine therapy uses iodine 131. If you remember, iodine 123 was used for investigation. Now for the treatment, you use iodine 131 because the half-life of iodine 131 is longer. It's up to 8 days. Okay? The half-life for iodine 131 is 8 days. So it is preferred in the treatment, in the radioactive iodine treatments. Now, you should know that the radioactive iodine treatment completely ablates the gland and subsequently patient becomes euthyroid. However, before commencing the radioactive iodine treatment, patients have to be made euthyroid using the antithyroid drugs, okay? You don't go straight ahead to commence radioactive iodine treatment in patients with thyrotoxicosis until you use the antithyroid drugs to render patients euthyroid. Then you now commence the treatment. Okay, here it is said that radioactive iodine destroy the cells and cause the complete ablation of the gland. The indications for radioactive therapy include primary thyrotoxicosis, an autonomous toxic nodule, and in a recurrent thyrotoxicosis. Now, if patients have recurrent thyrotoxicosis, they are at risk of injury when you do surgery. They are because of the distortion of the planes. There's also fibrosis, which will trigger more bleeding. And also there is more injury to the recurrent, tendency to injury to the recurrent laryngeal nerve. Okay, So usual dose is 5 to 10 millicurie or 160 microcurie per gram of thyroid tissue. The patient is made euthyroid using antithyroid drugs. Drug is stopped for 5 days. Then iodine 131, okay? Then iodine 131, 300 to 600 microcurie is given orally. Antithyroid drugs are started after 7 days and continued for 8 weeks. It takes 3 months to get full response, and so until then, patient has to take antithyroid drugs. Additional dose or 2 doses may be required to achieve complete ablation. Then they eventually become hypothyroid and therefore require maintenance dose of L-thyroxine 0.1 milligrams daily. To give a therapeutic dose, a patient should be admitted and isolated for 7 days to prevent irradiation. It is given orally. Now, the next treatment option we are going to talk about is surgery, which is thyroidectomy, okay? Now, what are the indications? Why will you do surgery for a patient with toxic goiter? Now, when patients have a failed medical treatment, okay? When a patient have a failed medical treatment, surgery is indicated. When a patient have a toxic solitary nodule, a toxic solitary nodule is indication for thyroidectomy because about 10% of solitary nodule are malignant. So it's better you do surgery. Patients with large glands, okay, when you have a large gland, they do not respond well to drug treatment. That gland have to be taken away, okay? You have to remove it. Patients with pressure symptoms, okay? Patient with pressure symptoms, you have to do surgery. Patients with malignant features is an indication for surgery, okay? Now, but you should know most thyroidectomies, the indication for most thyroidectomy is for cosmetic reasons. Most thyroidectomies are done for cosmetic reasons, okay? Now, you should also know patients that develop complications following drug therapy. You prefer to do surgery for them. Now, we are going to see the various types of surgery for thyroid. Okay, let us see the various types of surgery that are done for thyroidectomy. Now, let's start with a lobectomy, okay? When you say lobectomy, what does it mean to do a lobectomy? Now, if this is the thyroid gland, you have the right lobe and the left lobe. Lobectomy entails removal of an entire lobe, okay, the isthmus, and then a cuff of tissue from the contralateral lobe. That is lobectomy. Lobectomy means reducing, assume this is the disease, they say, do here, you want to remove the entire lobe, okay? The isthmus, and you now take a cuff of tissue from the contralateral lobe. The reason why you take a cuff of tissue here is because of maintaining symmetry in the neck. Okay, if you don't, so that the remnant will nicely fit into the side of the neck without causing any asymmetry in the neck. So that is lobectomy. Another option is subtotal thyroidectomy. Subtotal thyroidectomy means you are excising both lobes completely, leaving about 4 grams of tissue on each lobe. That is subtotal. So you remove the entire lobes and the isthmus, leaving 4 grams of tissue on each lobe. And the reason for this is to maintain, to preserve the thyroid function. Is to preserve the thyroid function so that patients don't have to be on thyroxine for life, okay? Another subtype of subtotal thyroidectomy, okay, is you remove an entire lobe, the isthmus, the contralateral lobe, preserving only 4 grams of tissue in the contralateral lobe. This is called Hartley-Dunhill's procedure. It's also a subtotal thyroidectomy. You preserve only 4 grams of tissue on only one lobe. So another option is the total thyroidectomy. The total thyroidectomy, you excise the entire gland, isthmus, and for these patients, you place on thyroxine for life. Patients have to be on thyroxine for life. Now, if you look at these two, what are the advantages and disadvantages of total thyroidectomy? Or what are the advantages and disadvantages of subtotal thyroidectomy? Now, if a patient have subtotal thyroidectomy, there is risk of recurrence because you are still leaving a remnant. There is risk of recurrence. And when they develop recurrence, operating a recurrent goiter, they have tendency to develop complications like injury to the recurrent laryngeal nerve. They have tendency for more bleeding, okay? So that is the disadvantage. And if there is a malignant focus, there is tendency of that remnant you left might be having a malignant, okay, focus. So now, what of total thyroidectomy? So, but the advantages, you see, patients won't have to be on thyroxine for life, okay, because you left a remnant of the gland that will preserve their thyroid function, okay? Now, for total thyroidectomy, the advantage, you remove the entire gland, no risk of recurrence, okay, no risk of leaving a malignant focus, the tendency of recurrence is not there because you've removed everything. However, patient is placed on thyroxine for life. So he has to be on drug for life. And this drug, where they are not readily available, it might be a challenge. Where they are not affordable, it might be a challenge. And also the issue of compliance. So those are the main problems when you are talking about total thyroidectomy. Okay, compliance, availability of drug, and affordability of drugs. Okay. Now, let's talk the next near total thyroidectomy. Near total thyroidectomy, you remove an entire lobe, you remove the isthmus, the contralateral lobe, you now leave only a rim of tissue. Only a rim of tissue, which is about 1 gram. And the aim is to preserve the parathyroid. The aim is to preserve the parathyroid. Okay. Now, we've talked about lobectomy, we've talked about subtotal thyroidectomy, we've talked about total thyroidectomy, we've also talked about near total thyroidectomy. Hemithyroidectomy is dividing, just as the name implies, hemithyroidectomy. Okay, so partial thyroidectomy are all these other types. Okay, subtotal, lobectomy, hemithyroidectomy are all types of. We are not going to discuss the operative details here. That will be in another session. But we will look at the complications of thyroidectomy. But by the way, you should know that the radioactive iodine therapy, okay, radioactive iodine therapy, it's contraindicated. It worsens the ophthalmoplegia. If a patient have eye signs and they are subjected to radioactive iodine therapy, it worsens their eye signs. And it's also not done in younger individual because of the tendency of developing malignancy in the later future. So it's preferred in patients that are more than 45 years. It is also avoided in pregnant women because it could be teratogenic to their babies. Okay. So what are the post-operative complications of thyroidectomy? Now, you should know that the post-operative complications of thyroid, one important complication of is airway obstruction. What are the various causes of airway obstruction in a patient who had thyroidectomy? One, it could be from tension hematoma, hemorrhage. Tension hematoma. And this bleeding usually is a reactionary hemorrhage. And after thyroidectomy, patient bled, and this bleeding accumulates in the pretracheal fascia. It can compress on the trachea and cause tension hematoma. Patient would present with severe respiratory distress, sweating, distended neck veins, okay, and they have marked respiratory distress. Here, the sutures are immediately removed, okay, to relieve the tension hematoma. Hemostasis is secured, okay, and the wound closed, and this is done in the theater, okay, to secure hemostasis. Patients have to be intubated and hemostasis secured, okay, and closed. Tension hematoma is a cause of airway obstruction, okay? Now, patients will have bilateral injury to the recurrent laryngeal nerve. And when there is bilateral injury to the recurrent laryngeal nerve, they will have complete closure of the vocal cords, and patient will go into airway obstruction. And this requires a tracheostomy. Now, patients might also have a tracheal collapse. This tracheal collapse is called tracheomalacia, and it is seen in long-standing goiter. After excision of long-standing goiters, the patients might come up with tracheomalacia, collapse of the tracheal rings, because that long-standing goiter have been stenting the trachea for a long time. So after removal, it collapses. Another cause of airway obstruction is laryngeal edema. And patients with laryngeal edema, this follows mainly difficult intubation. Patients with laryngeal edema following difficult intubation. Now, post-operatively, patients will have cough, hoarseness of their voice, okay? Now, if a patient suffers laryngeal edema, they should have steam inhalation, they should be given steroids. Steroids should be administered to relieve the inflammation, okay? So, these are various causes of airway obstruction following thyroidectomy, okay? Another complication is recurrent laryngeal nerve paralysis. Recurrent laryngeal nerve paralysis, okay? Now, when patients have a recurrent laryngeal nerve paralysis, they can present with hoarseness of the voice, hoarseness of their voice, okay? And we should know that this injury might be transient, okay? They tend to recover within 3 to 9 months. But when it persists after 9 months, they must have an operation, okay? There should be lateral fixation of the vocal cord, which is called Woodman's operation. Woodman's operation is a lateral fixation of the vocal cord, okay? So another complication is hypoparathyroidism. Hypoparathyroidism. Now, hypoparathyroidism occurs when there is an inadvertent removal of the parathyroid gland. We mentioned the parathyroid gland role is for calcium metabolism. So when you remove the parathyroid gland, the serum calcium is low, and these usually occur in 3 to 5 days, okay, 2 to 5 days, after the operation, and they start, you notice circumoral numbness, tingling sensation, facial twitches. They come up with carpopedal spasms, and here you have to administer calcium gluconate, okay? You have to give calcium gluconate at a loading dose, then you now place them on a maintenance calcium gluconate. And when patients develop all these, you have to test bedside. Remember the Trozier sign and the sign for checking for hypocalcemia. Okay. Now, patient might also present with thyrotoxicosis. exaggerated symptoms of thyrotoxicosis in a patient that was not made euthyroid before surgery. You have to make patient euthyroid before surgery, because if patient is operated upon, this manipulation of the gland and release of a lot of hormones into the system, and this will lead to symptoms of thyroid storm, and this will present with excessive sweating, tachycardia, okay, and hypertension. And when these occur intra-op, you have to give parenteral propranolol, okay, intra-op. Other complications will include injury to the external branch of the superior laryngeal nerve. Patient will present with inability to achieve a high-pitched voice. Okay, they might also have late complications. Okay, like hypothyroidism, which usually occur in 3 to 5 years after thyroidectomy, and patients will be placed on L-thyroxine. When they have the late complications like hypothyroidism, patient will have slot speech. They have to be placed on L-thyroxine. This is one of the diagnoses we can make over the phone. Okay. Now they will have recurrence. About 10% of patients who have subtotal thyroidectomy may present with recurrence in 1 to 4 years after surgery. And also patients who are prone to keloids, they might present with keloid, because that is an area that is predisposed to keloid formation. So we've come to the end of today's lecture. Malignant goiters will be taken in another session. So now I'm going to entertain questions. So we are going to go to the question and answer session. If you have any questions, you ask your questions. Okay. So if you have any question, you can unmute yourself and you ask questions. Then I'll respond to the question. Any question?